สวัสดีครับ My name is Chayapuk Pandi. Today we are going to talk about evaluation of the basal metabolism of degenerative lumbar intervertebral disc based on Fuhrman grade and presence of instability. As we know, IVD degeneration is implicated in back pain and spinal related disability. It may cause segmental instability. Our hypothesis is higher Fuhrman grade and radiographic instability would produce higher levels of degenerative enzymes and inflammatory mediators. This is a pilot project experimental study. Fuhrman grading was determined instability based on presence of spondylolisthesis. We took IVD from the human subject for biomarker evaluation. Media were tests. T-tests were used in this study. Our results found that no significant difference between basal biomarker production by degenerative IVD tissue of Fuhrman grade 3 versus grade 4 disc. However, tissue from degenerative IVD with spondylolisthesis produced significant by higher levels of MMP8 and significantly lower levels of MMP1, MMP2, and MMP13 compared to tissue from stable spine. In summary, my study indicates potential difference in degenerative enzyme production by IVD degeneration based on the presence of spondylolisthesis. The ultimate goal of this study will be useful to provide preoperative tools for treatment decision making and targeting therapy in the future. That's all of my presentation. Your questions will be entertained.
Hello, I am Christian Rodriguez, a medical student at the University of Pennsylvania working under the guidance of Dr. Kamran Saifi, and I will be talking about modeling the adjacent segment biomechanics of a T10 pelvis spinal fusion. Proximal junctional kyphosis and failure are challenging complications of long fusion constructs. The aim of this study was to investigate the biomechanical stresses adjacent to the upper instrumented vertebra of a T10 pelvis fusion by analyzing post-fusion changes in compressive and shear forces at the T9 vertebra. The pre-fusion models were subject-specific spine models that incorporate the height, weight, spinal curvature, and muscle morphology measurements of 250 individuals. Models were further modified to eliminate motion between the intervertebral joints from T10 to the pelvis, and open sim analysis tools were used. Differences between pre-fusion and post-fusion T9 biomechanics were consistent between increased segmental mobility and unchanged segmental mobility. Average compression significantly decreased during all simulated motions. Average anterior-posterior shear force significantly increased during trunk flexion and during axial twist. Average medial lateral shear force significantly increased during trunk flexion. Our analysis showed that multi-level fusion causes an increase in shear forces and a decrease in compressive force at the T9 vertebra. The increased shear force may increase stress on the posterior ligamentous complex, facilitating the development of PJK. Although acutely there is decreased compression, we predict that chronic degeneration of PLC facilitated by increased shear stress may lead to an increased bending moment with increased compression. Thus, to prevent PJK, surgeons should place emphasis on maintaining the integrity of the PLC or utilize novel techniques to either stabilize or enhance the PLC. Thank you.
This research is from the Medical College of Wisconsin, Department of Neurosurgery and Biomechanical Engineering. We are looking at the problem of spinal metastasis and the potential for pathologic fracture. We're investigating the biomechanics of different degrees of metastatic involvement under pure compressive and combined loading. We had 6 clinical scenarios: healthy spine, osteoporotic spine, both 40 and 80% METs to the vertebral body, and addition of 4 cc's PMMA in each of the 40 and 80% METs respectively. We had pure compression and combined compression and bending moments. This was representative of carrying and lifting 10 kilograms from ground or tying shoes. The parameters measured were range of motion, vertebral body forces, and discal pressures. As you can tell from our graphs, increasing metastasis resulted in an increased range of motion up to the 40% mark. However, after that, There was a decrease in the vertebral body forces and discal pressures. Insertion of PMMA in the 40% vertebral body allowed restoration of range of motion, vertebral body forces, and discal pressure. This was not observed in the injection of PMMA in 80% mets. What this shows us is increased metastatic burden, increases instability, and hence the chance for pathologic fracture. Adding PMMA in the 40% mets allowed the patient's ADL safety without the risk of pathologic fracture. However, 80% mets, the risk of pathologic fracture and instability was too great and risks neurologic injury. Thank you.
Good morning. Orthopedic clinician treating spinal trauma case generally observe patients who are complaining about continuing pain around the thoracolumbar spine up at the nerve root for no good explanation. Indeed, many of these patients has trivial body fracture with intact posterior element. So this was the purpose of the study. Axial loading has been implicated in over 86% of thoracolumbar fracture. Hence, the purpose of the study was to examine the effect of vertebral body fracture on the intervertebral foramen. So we used input acceleration to the seat bottom by inferior superior direction. The question then comes, can you have a foraminal narrowing and presume clinical compliance with lesser degree of vertebral body fracture? To examine this, we used 36 unembalmed thoracolumbar spinal column. Pre and post-test X-ray and CT scans were captured. Vertebral body fractures were graded based upon the compression of the vertebral body and was classified as stated in bullet point 3. We then performed foraminal measurement looking for the evidence of disc collapse, and the parameters used are listed in the last point. Here is what we found: 22 moderate injury and 8 severe injury. The third bullet lists the criteria we used for evaluating the foraminal compromise. From the table, we can observe that 10 of the 22 moderate injury cases had foraminal compromise, which was a significant number. So what is this study tells us? First of all, there was no big surprise that most of the severe injury cases had IVF low below the critical value. Surprise was that 45% of the moderate case did it as well. Certainly, we were not expecting that phenomena. In an ongoing companion study, senior author reviewed 950 records of the patient with compression fracture, and of that, 11 of the 24 patients with isolated radiculopathy had AIS-1 or AIS-2 injuries. Thus, even patient with minor fracture that not even recognized in imaging may have IVF compromise and have associated clinical complaints. Thank you.
Thank you for the invitation. My name is Hoon Choi from Medical College of Wisconsin. I'd like to talk about our biomechanical study using finite element model to look at anterior versus posterior lumbar fusion approaches. We generally look at the index level pathology, stenosis, instability, and perhaps sagittal balance and pelvic incidence and lumbar lordosis mismatch, but we often don't look at the adjacent levels enough when we consider anterior versus posterior fusion approaches. So we used our L3 to S1 and S2 sacrum osteoligamentous finite element model to simulate L4-5 ALIF and L4-5 PLIF. We used this model to morph and change the different anatomical parameters to simulate 300 different patient anatomies, and then we loaded it with 5 Newton meters of flexion, 400 newtons of compression, and we measured motion, disc stress, and vertebral body force. We found something very interesting. So L4-5 ALIF was actually sensitive to the L5-S1 disc height, and L4-5 PLIF was sensitive to the superior L3-4 disc height. So our conclusion was ALIF is a better option if there's early degeneration at the superior adjacent level. You shouldn't really do this at L4-5 because L5-S1 level, if it has slightly decreased in height, it's going to increase the disc stresses at different levels. TLIF, PLIF, it's okay to do this at L4-5 because it is more sensitive to the superior adjacent level, not the inferior. So TLIF, PLIF is a better option if there's early degeneration at the inferior adjacent level. Thank you for your attention.
This was research from the Medical College of Wisconsin Department of Neurosurgery and Biomechanical Engineering. The purpose of this study was to use finite element to determine the effects of adjacent segments on 6 different interbody fusion techniques at the L4-5 level in a degenerative spondylolisthesis model. problem that we're trying to address is that of adjacent segment stenosis, which is a cause for revision surgery in approximately 20 to 25% of cases. We have 6 clinical scenarios in an intact spine. This includes a standalone A-lift with posterior instrumentation or 360, T-lift unilateral and bilateral, both with posterior instrumentation, and PLIF with 1 cage, 2 cage, and posterior instrumentation. Measurements were made on range of motion, vertebral body forces, and intervertebral discal pressures. As you can see from this graph, as expected, the 360 appeared to be stiffest and had the most significant decrease in range of motion. The most flexible construct was the standalone A-lift and the unilateral T-lift with posterior instrumentation. We were able to show that vertebral body forces and intervertebral disc pressures were higher, cephalad to the fusion, and end plate stresses were higher at the caudal aspect of the fusion. We've shown that adjacent segment stenosis would be predicted to be higher in the cephalad segments and subsidence of the implants higher in the caudal end plates. Our conclusion is that finite element analysis can be used to help determine optical surgical procedure selection and can hopefully be used to try to minimize adjacent segment disease and the need for additional surgeries. Thank you.
My name is Joshua Eisenberg with the University of Iowa Department of Orthopedics. Our team, led by Dr. Andrew Pugley, looked at post-op analgesics following primary lumbar fusion. Prior data suggests NSAIDs have an inhibitory effect on healing following spine fusion, while opioids have been associated with worse outcomes yet remain the most common method of post-op pain control. As medicine moves closer to a value and outcomes-based form of reimbursement, along with national pressures to reduce narcotic use, there is sustained interest in determining the optimal post-operative pain regimen. The purpose of this study is to assess whether the use of certain analgesics in the immediate post-op period are associated with increased risk for revision lumbar fusion for presumed non-union. This was a retrospective cohort study using a large data set. We were able to query patients undergoing primary lumbar fusion between the years 2010 and 2016. Multivariable regression models were used to identify new analgesic prescription fills within 30 days post-operative to assess relative risk for revision surgery within 1 year of the index surgery. Over 200,000 patients underwent primary lumbar fusion during this period. Of these patients, over 3,500 or 1.6% required revision arthrodesis in the first year. Our multivariate regression models identified patients with new COX-2 inhibitor prescriptions to be at an increased risk for revision arthrodesis, similar to those with NSAID and opioid prescriptions. These were all statistically significant. Those with new tramadol prescriptions were at a slight decreased risk, however not statistically significant, with an odds ratio of 0.91 and a p-value of 0.18. Like opioid use of NSAIDs and COX-2 inhibitors prescribed within 30 days post-op period were associated with increased risk for revision surgery within the first year. Conversely, tramadol was not strongly associated with increased risk of revision surgery, suggesting tramadol may be an effective analgesic with lower risk for complication compared to other modalities. Of course, further work is necessary to find the optimal patient-specific pain regimen. Thank you.
Hi, my name is Andrew Chan, and on behalf of the Quality Outcomes Database Spondylolisthesis Study Group, I'd like to present to you our work looking at reoperation following single-segment surgery for myodine grade 1 degenerative lumbar spondylolisthesis. I'd like to thank the NREF for their contribution to our study. So we know that 2 surgical interventions are widely utilized in the management of spondylolisthesis. This includes decompression alone and decompression with the addition of fusion, and the ideal approach remains controversial. One of the ways to compare the 2 approaches is to assess their respective impacts on reoperation. And we did just this using the prospective multi-center QOD spondylolisthesis registry. We compared the 24-month reoperation rates for 140 patients undergoing decompression alone and 468 undergoing decompression and fusion. At baseline, there are multiple differences between the cohorts, and these were subsequently adjusted for in multivariable analyses. So looking at reoperation rates, we found that they were similar for the decompression alone group at 9.3% and the decompression infusion group at 6.2%. The timing of reoperations, however, did differ, with the decompression infusion group having more reoperations within 30 days, but the decompression alone group having more reoperations between 30 days and 1 year. There were no differences from 1 to 2 years and 2 to 3 years. In multivariable analyses, we found that reoperation occurrence was associated with worse 24-month outcomes for all our PROs. This persisted in subgroup analyses of those receiving fusion alone, but not in the decompression alone cohort. So in conclusion, though the reoperation rates are similar between patients receiving decompression and decompression with fusion, the timings differ. Fusions have a higher rate of reoperation within 30 days, whereas decompressions were associated with a higher rate between 30 days and 1 year. When reoperations occur, they have a significant and negative impact on 24-month outcomes, but may have less of an impact when they occur following decompression surgery.
Hi, my name is Shane Sharistani, and this talk will focus on the use of frailty for improving predictive models regarding primary and secondary lumbar spine tumors. Overall, malignant spine tumors are common, and improved diagnostic and treatment strategies have increased survival times. Age has been popularly analyzed as a predictor for postoperative complications within these patients. However, frailty may be superior in predicting patient outcomes. For the methods, our study designed as a retrospective cohort using the Nationwide Readmission Database, or NRD. We used years 2016 and 2017 and excluded patients with spinal trauma. For frailty coding, we used ICD-10 codes as indicated by the Johns Hopkins Adjusted Clinical Groups code. We used propensity score matching for age, sex, CCI, which is Charleston Comorbidity Index, surgical approach, number of levels between frail and non-frail patients. And we used ROCs and AUC values to evaluate our models. Our results suggest that frail patients have higher LOS, costs, infections, post-hemorrhagic anemia, and UTI, even after matching. Frail patients also had higher rates of non-routine discharge compared to non-frail patients, and regression models were all improved when using frailty rather than age. Here you can see the regression models, and you can see in black, all of those curves are performing better than those using age in red. And overall, frailty is a better predictor of complications, LOS costs, and readmission compared to age, and future studies should really look into this further to most accurately triage patients and stratify risk. Thank you.
Relative safety of lumbar drains for management of postoperative CSF leaks in the thoracolumbar spine. CSF leaks pose a substantial danger to patients. Early recognition is important, and treatment can be difficult. One method that may be helpful for the treatment of patients with a difficult condition is the use of lumbar drains. Today, we will talk about the incidence and potential complications of lumbar drain placement. This is a retrospective chart review that looked at patients who were treated surgically. 61 patients were evaluated. These were patients that had CSF leaks. 48 that did not have placement of lumbar drains. 13 who had placement of lumbar drains as part of their management. We calculated complication rates and analyzed the types of complications. This is the results section of our slide. It shows that the complication rates for patients with lumbar drains were not statistically different from those who did not have lumbar drains. Their hospital duration, however, was longer for patients with the placement of a subarachnoid or lumbar drain. The patients themselves, from a demographic standpoint, were the same in terms of age and gender, whether they had a revision surgery or not, and the number of levels that were decompressed. If we look at the types of complications that occurred, a single patient with a lumbar drain experienced meningitis. On the other hand, patients without lumbar drains had noted other complications, to include 2 patients with a deep vein thrombosis, 1 patient with a pulmonary embolism, and 3 patients with postoperative wound infections. So the conclusion is that lumbar drain placement is a reasonable and safe option for the management of CSF leaks. This is a limited study based on its retrospective nature and its relative small sample size.
Postoperative urinary retention is not associated with increased 90-day readmission or ER visits in patients undergoing lumbar spinal surgery. For patients undergoing lumbar spine surgery, it has been estimated that POR affects between 5.6 and 39% of patients. Patients who develop POR have been shown to have higher dissatisfaction scores, higher rates of UTI, being admitted to skilled nursing facilities, and sepsis. And the aim of this study was to analyze the impact of POR on 90-day readmission and ER visits. We retrospectively analyzed patients from 2017, when an institutional standard for POR was implemented, to 2019. Demographic data, as well as all-cause 90-day readmission and ER visits, were analyzed. A total of 2,529 patients were analyzed, and of those patients, 175 of them developed POR. There is no difference in age, gender, length of stay, and surgery time in those patients that developed POR compared to those who had not. And additionally, the all-cause 90-day readmission and ER visits was not statistically significant between the two groups. We did a sub-analysis to compare patients undergoing laminectomy and instrument infusion versus laminectomy or laminotomy alone, and what we found is that 8.8% of the fusion group developed POR compared to 5.6% in the laminectomy or laminotomy alone, and there was a higher proportion of all-cause 90-day readmission and ER visits with the instrument infusion group. In conclusion, patients with POR at the time of discharge were not more likely to have a 90-day readmission or emergency center visit following spine surgery. Patients treated with laminectomy and instrument infusion had a higher percentage of postoperative urinary retention, as well as a higher proportion of all-cause 90-day readmission or emergency center visits.
Good evening, I'm Christopher Martin from the University of Minnesota. We all know that long-term failure of pelvic fixation can occur with an incidence up to 29% in some series, but typically the reported mechanisms are associated with fatigue failure, such as screw or rod breakage or screw loosening. However, acute catastrophic failures have not been well described. At our own institution, we reviewed 18 months of consecutive cases. These were all surgeries from L3 to the pelvis or higher, and we defined failure as occurring within 6 months of the index procedure and requiring surgical revision. We found an unexpectedly high incidence of 5%. It was 6 of 125 cases, and all of the failures happened within 6 weeks postoperatively, so they were very acute. Failure patients tended to be younger and tended to have undergone large magnitude surgical corrections, as defined by the number of levels fused, as well as by the radiographic parameters you see listed here. In the multivariate analysis, the most significant variables were younger patient age and change in lumbar lordosis. Of the 6 patients we revised, 3 of those we attempted to revise initially with less than 4 points of pelvic fixation, and 2 of those 3 went on to sustain a second failure. So we learned from this process that if you're revising one of these failures, you need at least 4 screws and 4 rods to the pelvis. In summary, these acute failures involved large magnitude corrections that likely exceeded the implant tolerances. We recommend if you're doing a large magnitude correction, consider placement of multiple pelvic fixation points and multiple rods, and if you're doing a salvage, at least 4 rods to 4 pelvic fixation points. We plan to follow this single center study up with a multi-center review, and those results will also be presented at LSRS this year.
I'd like to acknowledge my co-authors and thank the committee for the opportunity. Adult spinal deformities and cervical deformities are complex disease states that can pathologically alter posture as well as have the ability to result in substantial pain and disability. Cervical and thoracolumbar malalignments can often occur concurrently, up to 53% of the time, and cervical deformities may also result as compensatory mechanisms following thoracolumbar deformity development or treatment. It is currently unknown whether specific patient or operative factors are associated with autocorrection of cervical spine malalignment after surgical correction of thoracolumbar deformity. Our objective was to assess preoperative radiographic parameters predictive of autocorrection of cervical malalignment in patients undergoing adult spinal deformity thoracolumbar surgery. This was a retrospective cohort study of operative ASD patients that were defined radiographically. Patients with a cervical diffusion at the time of the index surgery were excluded. Cervical deformities were also defined radiographically, and if a patient met cervical deformity criteria at baseline but not at 6 weeks postoperatively, they were considered autocorrected. Binary logistic regression with conditional inference trees for continuous variables determined thresholds predictive of autocorrection. These relationships were further explored with multivariate regression and ROC characteristics. 120 patients were included, 82% female. The majority of these were treated by posterior-only approaches. 54% of patients had preoperative cervical malalignment. In terms of autocorrection rate by 6 weeks postoperatively, almost 30% of patients with preoperative cervical malalignment no longer met radiographic cervical deformity criteria and were considered autocorrected. 23% of preoperative cervical deformity patients remained autocorrected until 2 years. With regards to postoperative development of cervical deformities, among patients with baseline cervical malalignment, that is approximately 45% developed cervical deformity within 2 years. Looking at our predictors of autocorrection by univariate analysis, 6-week autocorrection had lower baseline T1 slope, cervical lordosis, C2, T3 angles, and less pronounced thoracic kyphosis, and CITs determined the following thresholds. Binary logistic regressions confirmed that all thresholds were significant, and multivariate regression ROC analysis, accounting for these radiographic thresholds as well as age, CCI, BMI, osteoporosis, and age-adjusted SVA, resulted in a predictive model with a predictability of 94%. In conclusion, in our cohort of 120 ASD patients with 2 years of follow-up, autocorrection of cervical deformity following thoracolumbar, ASD correction occurred in almost 30% of patients by 6 weeks post-op. Autocorrection occurs in patients without baseline cervical lordosis, with modest T1 slope and less pronounced thoracic kyphosis. In ASD patients with similar characteristics to those in this study, reconstruction should perhaps not routinely be extended into the cervical spine. Thank you for your time.
Hi, my name is Kieran O'Leary. I'm a spine fellow at HSS, and I'll quickly be presenting our study looking at neuromonitoring alerts during lateral lumbar interbody fusion. We have no disclosures related to this talk. Neurologic complications after LLIF are one of the most common complications. Most LLIF systems today use EMG, but some studies have questioned the utility of EMG during LLIF. Newer studies are starting to look at multimodal intraoperative neuromonitoring, including the use of SSEPs and MEPs, but the ideal neuromonitoring strategy is yet to be determined. The purpose of this study was twofold. One, to identify whether alerts occurred more frequently when more lumbar levels were accessed, and two, whether alerts occurred more frequently at a particular lumbar level. For the methods, we use 2 commercially available intraoperative neuromonitoring databases to identify patients undergoing LLIF between L1 to L5. All patients had at least one intraoperative neuromonitoring modality used. The type of intraoperative neuromonitoring modality used and the incidence of alerts were collected from each neuromonitoring report. And the incidence of alerts based on the type of neuromonitoring used, whether that was SSEPs, MEPs, or EMGs, was analyzed based on how many levels were accessed and at each particular level accessed during LLIF. In total, 628 patients were reviewed undergoing LLIF at 934 levels. EMG was used in almost all the patients. SSEPs were used in almost 90% of patients, and MEPs were used in a quarter of patients. The frequency of alerts, regardless of modality, did not increase as the number of levels increased. No alerts, whether that was EMG, SSEP, or MEP, occurred at L1 or L2. EMG alerts from L2, 3, L3, 4, and L4, L5 were similar in distribution and frequency. However, SSEP and MEP alerts were significantly more frequent at L4, L5 versus L2, 3, and L3, 4, and all MEP alerts occurred at L4, L5. So in conclusion, it may be that intraoperative neuromonitoring modalities provides the greatest utility at L4, L5, particularly MEPs, and may not be necessary for more cephalite procedures such as at L1, L2. Future studies based on the results of these studies should investigate the selective use of multimodal intraoperative neuromonitoring during LLIF, with the hypothesis that SSEPs and MEPs may have lower utility at the upper lumbar segments, but added utility at lower lumbar segments. Thank you.
Hello, my name is Galbar Kai from the Sheba Medical Center in Israel. This presentation is early surgery for thoracolumbar extension type fractures in geriatric patients with spinal ankylosing disorders decreases perioperative patient complications. Geriatric trauma patients with spinal ankylosing disorders are susceptible to unstable vertebral fractures following even minor trauma. These patients are most often treated surgically. In this study, we aim to assess the relationship between the timing of surgery for unstable vertebral fractures in this population and patient outcomes. As to the methods of our study, our inclusion criteria were a diagnosis of a thoracolumbar extension type fracture, radiographic diagnosis of tissue or ankylosing spondylitis, age over 65, and lower energy trauma. Our exclusion criteria were any additional injuries and prior spinal instrumentation. The difference in patient outcomes that underwent early surgery of less than 72 hours, as opposed to those that underwent later surgery, was assessed. A total of 47 patients were included in this study. 19 of them in the early surgery group and 28 in the late surgery group. No difference was found in age and Alex-Hauser comorbidity scores between the groups. 10% of the patients in the early surgery group were found to have perioperative complications, as opposed to 64% of the patients in the late surgery group. This finding was statistically significant. Another interesting finding was a perioperative mortality of 10% in the early surgery group and 25% in the late surgery group, although this finding was not significant. Additional outcome measures were not found significant. In conclusion, time to surgery may affect complication rates in patients of the elderly population with spinal ankylosing disorders presenting with unstable hyperextension type thoracolumbar fractures. Early surgery in this patient population should be considered. Further research should be conducted in order to assess additional outcome measures. Thank you very much.
Hi, my name is Alvin Chan, and I'm a PGY3 neurosurgery resident at the University of California, Irvine. This talk is entitled Greater Increase in Foraminal Height and Area After A-Lift at L5-S1 Compared to Other Levels as Measured by CT. A-lift has been shown in the literature to decompress the foramen by increasing the lumbar lordosis. There have been previous studies showing A-lift providing substantial decompression. Our objective was to evaluate foraminal height and area using pre- and post-CTs for measurement. This was a retrospective analysis of 48 patients who underwent A-lift with at least 1 year follow-up. Pre- and post-operative CTs were used for measurements. Different variables were collected including demographics, cage parameters, disc height, foraminal height, and foraminal area. Paired t-tests and ANOVAs with post-hoc Sheff tests were used for statistical analysis. Overall, there was a significant increase in the foraminal heights and areas for L5-S1. This was not consistent at L3-4 or L4-5. The disc heights did increase significantly for L4-5 and L5-S1, but not L3-4. Furthermore, tall implants were positively correlated with larger foraminal size at L5-S1 but not L3-4 or L4-5. There was no association between the degree of lordosis and foraminal size. In conclusion, A-lift increased foraminal size at L5-S1 and implant height was correlated with larger foraminal size. Degree of lordosis did not affect foraminal size. Limitations include no patient outcome analysis and the retrospective nature of this study. Thank you for viewing.
The title of our study is Physical Therapy on Postoperative Day 0 Following Lumbar Spine Surgery Decreases Length of Stay. This study was performed at the University of Missouri-Columbia. Lumbar spine surgery is among the most effective procedures in orthopedic surgery, and annual utilization continues to increase. The postoperative inpatient length of stay is a major factor in the cost for spine procedures. Discharge timing often depends on physical therapists who determine whether patients can ambulate to safely meet their needs. The goal of this study was to determine whether inpatient lumbar laminectomy patients who started formal PT on postoperative day 0 instead of postoperative day 1 have shorter postoperative length of stay. A retrospective cohort review was designed for 1,870 patients who underwent elective 1 to 2 level laminectomies. Exclusion criteria consisted of incomplete data, admission under trauma visit, admission to ICU for observation or complications, and lack of formal PT encounter before discharge. A total of 336 patients met inclusion criteria. Formal PT was initiated on postoperative day 0 for 202 patients and postoperative day 1 for 134 patients. There were no significant differences between post-op day 0 and 1 groups regarding demographics or BMI. For patients who initiated PT on post-op day 0 versus day 1, a significant decrease in length of stay of 9.9 hours was noted. Finally, the distribution of postoperative nights spent in the hospital was also statistically significant, such that a higher percentage of patients who received PT on post-op day 0 were discharged after 1 to 2 nights in the hospital, compared to patients who started PT on post-op day 1. Overall, lumbar spine patients who initiated PT on post-op day 0 demonstrated clinically and statistically earlier discharge than those on post-op day 1. Given the role of length of stay in quality metrics and reimbursement, orthopedic surgeons may consider optimizing post-op length of stay with a multidisciplinary approach that includes physical therapists. Thank you for your time.
My name is Brian Cramy. I'm one of the Rothman Spine Fellows. I'll be presenting robotic versus freehand screw placement, a comparison of one-year clinical and surgical outcomes for lumbar fusion. The purpose of this study was to compare clinical and surgical outcomes after 1 to 3 level lumbar fusion using either robotically assisted versus freehand pedicle screw placement. We took patient data from 2014 to 2020 at our institution. The clinical outcomes of interest included delta, or the perioperative change, in patient-reported outcome measures, ODI, PCS, and MCS-12, VAS back and leg at 1 year. From this, we also calculated recovery ratio and the proportion of patients achieving the MCID. Our surgical outcomes of interest were complication and revision rates. There were a total of 262 patients in our cohort, 177 in the freehand group and 85 in the robotic group. There were no significant differences with regards to demographics between groups. However, when you look at the number of levels fused, there was a higher proportion of patients undergoing 2 and 3 level lumbar fusion in the freehand group as opposed to the robotic group. When we look at our surgical outcomes, there was no significant difference in revision or surgical complication rates between groups. However, this study may have been underpowered to detect this difference. Evaluating clinical outcomes within each group, significant improvements were achieved across all outcome measures. However, between groups, no significant differences were noted in our delta scores, recovery ratios, or MCID. A regression analysis is presented in the table you see here, demonstrating that the perioperative change in patient-reported outcomes was no different between groups, even after controlling for demographic characteristics and the number of levels fused. In short, the touted benefits of robotically assisted pedicle screw placement may not translate to meaningful clinical improvements for patients. No significant differences were found in patient-reported outcome measures, surgical complications, or revision rates in a large cohort of patients undergoing 1 to 3 level lumbar fusion at our institution. Thank you.
Hi, my name is Brandon Ishida, and I will be discussing post-operative function after minimally invasive spinal surgery, or MIS for short, versus open spinal surgery for lumbar spine decompression. The goal of our study was to determine if patients who underwent MIS had better post-operative functional outcome scores than patients who underwent open surgery for lumbar spine decompression. Our study was a retrospective chart review from a single academic center. All patients who underwent either MIS or open surgery for lumbar spine decompression were included. Post-operative function was measured using the Oswestry Disability Index score. Between the MIS and open surgery groups, estimated blood loss and perioperative morphine equivalent use were both significantly greater in patients who underwent open surgery. However, all other demographic, perioperative, and post-operative variables were not significantly different between the two groups. At baseline, patients who were scheduled for MIS versus open surgery had no significant difference in neither preoperative nor postoperative ODI scores until patients' 1-year follow-up, at which point patients who underwent MIS had significantly lower ODI scores. However, at all postoperative time points, there is no significant difference in the change in ODI score with respect to patients' preoperative score. In summary, patients who underwent MIS had significantly reduced perioperative morphine equivalent usage, decreased estimated blood loss after surgery, and lower ODI scores at their 1-year follow-up, while having similar operative times, number of complications, and number of revision surgeries. This suggests that MIS is a comparable alternative to traditional open techniques for surgical decompression of the lumbar spine with regards to achieving improved short-term postoperative outcomes without increased operative times, complications, or revisions.